Hi everyone, I am Ruban. I'm one of the trainers here at Quadra, working across our software products range. At Quadra, we focus on creating really practical bespoke digital solutions for orthopedic and podiatry world. And today I'm excited to chat through the full setup we offer for the podiatrists and to show how it all fits together in real clinic practice with Ian Sandler. Ian, yes, the first slides.
Yep, perfect. There we go.
Yeah, so we have a complete solution from scan to print. So when you talk about the scans, the first one is the scanner. The good news about the scanner, you don't need any huge or complicated equipment anymore. At the moment, so an iPhone or iPad, more than enough to do the scans, and our Arkad app works on both, and it lets you take a full or partial or non-weight bearing scans real quick. It's simple, accurate, and super easy to use. And so once you have the scans ready, the next one is the software. The one we got here is called Arkad Soft. So everything happens inside the Arkad Soft is a kind of the bespoke design workspace. So you got full pads, a library, customized templates, and range of different densities from 30 to 80 shows. So you can tweak the orthotic exactly how you want it and basically give you full control without slowing you down. So next one is our Arkad printer. This is where your file is going to be printed. So Ian, yeah, next one. Right, so our printer is quite unique. So the CAM have a capacity to do almost 17 different densities from 30 show to 80 shows. And the insoles can be customized on the back of these, the names or whatever you wanted to print. Also, you don't need any human intervention. We can continuously print throughout the 24/7. There are lots of advantage with this printer. So, as most of you know, our industry is going forward with the digital workflows and additive manufacturing. And Ian is a great example of this. How can we work in real life? He's taken the whole system, scanning, designing, and 3D printing, and built it straight into his clinic workflow. And most importantly, he is successfully treating every day with this technology with his old patients. So, having said that, Ian Sandler is a biomechanic podiatrist with nearly 30 years of experience. So, which basically means he's seen every type of heel pain you can imagine. Ian's known across the UK of highlighting that there are actually over 40 different causes for heel pain, not just plantar fasciitis. And his work has really changed how clinicians think about it. So he's also a fantastic educator, helping clinicians feel more confident with diagnosis and orthotic prescription. And today he is here with us through his collaboration with Quadra, sharing how 3D printed orthotics can take patients' care to the next level. So let's give a warm welcome to Ian Sadler, and he's the one thinking about this heel pain in a different ways, and he already did some researches and stuff. So let's give him a warm welcome to Ian Sandler, and then he is going to take the presentation from here. Thank you, Ian. Thanks for your time.
Yeah, thank you very much, Ruben. We'll have a little dance through heel pain. So thank you very much for giving me the platform to have a bit of a chat about heel pain and prescribing orthotics to try and help it where they're suitable in treatment planning. So if you want to follow me at all, you can see some credentials up there for both Instagram and Facebook, but we'll go through some of these as we go as well. So as I'm possibly a new face for a lot of you, a little bit of an introduction to myself. So I am as Ruben said, biomechanics specialist, but with podiatry as my focus. So we sort of do lower limb biomechanics. I run a clinic which we've been working with sort of technologies for gait analysis and biomechanics and now orthotics production for about 20 years. And we essentially see the whole gamut. We see children, we see all the way up to So 80, 90-year-olds. Heel pain affects all of those different people. So for the context of this, and we'll sort of talk through some of the experience there using a couple of case studies. The reason for the picture on the right there is I also have a military background for medicine. So I was a medic within the army for 5 years with the regulars, as a paratrooper with the other elite and special forces. And then I did nearly 14 years as a physical training instructor with the Army Reserve. So we've got lots of experience with athletes of different levels, people going through training, injury rehab, and all of the areas around there, as well as the nice cozy environment of a clinic. So as Ruben was alluding to, we've got two strands to the business. So we've got the BX Clinic, which is based in Norfolk. So sort of, I've lost the cursor on here. So based in Norfolk, which is about 2 hours northeast of London in the UK. And we also have BX Co Limited. So BX Co is our training and our manufacturing. So because we've had to try and find solutions that meet the modern theories of how orthotics and biomechanics actually work and we can implement, that's what drew us to the Arkad system. And we've basically built a system where within our clinic, as Ruben said, we've got the complete solution. So we take the scans in-house, we do the CAD, the design of the insole in-house, and we also do the printing in-house. But we also offer training and education to clinicians who want to bring biomechanics and orthotics in to their practice, and you could use us as a supplier of that once you've done the training. Equally, we can offer CAD as a service or just the printing. So if you wanted to do your own CAD and have us print it without having to invest in that, they're all options for you within the UK using the facility. So the purpose of today is sort of take you through some of the things that we might be able to do with that type of technology that we can't do just with ordinary orthotics. But we'll also do a bit of a CPD update on plantar fasciitis. So things we're going to cover today. What is plantar fasciitis? It's more than just sticking a label on it of plantar fasciopathy, because that's convenient clinically. So we'll talk to some of the nuance of that. We're going to use case studies to outline the diagnosis, treatment planning, and we're going to base that treatment planning on our clinical assumptions and the patient-focused needs. We're going to look at some orthotic insole considerations when prescribing for heel pain, particularly with pertaining to the sorts of things we can now offer. And we're going to use a common and less common presentation of heel pain to demonstrate that. So, first of all, what is plantar fasciitis? So it's generally used as an umbrella term for all heel pains, really. So if we're completely honest, plantar fasciitis for years has just been used as this sort of catch-all term for pain under the heel or towards sort of arch or back of the foot. The thing I was taught in my undergraduate, and I think is still taught today, is that what you're listening for in your clinical assessment or your history taking is that the heel area is painful on rising. From rest, it eases off with some degree of movement, but then returns later. All right, so that was certainly what I was taught in my undergraduate, and it seems to be still the common sort of phraseology that we're supposed to listen for. The problem with that is, after you've been working with people with heel pains for not very long, or even foot pains in general, you'll observe that almost all foot pains respond like that. So when you get up and start moving, the hurty bit either gets squished or stretched or somehow begins to hurt more. Then you start to ease off a little bit, and then it starts to come back the more you've used it. So I think this is where we get a lot of confusion about what is plantar fasciitis and what is not plantar fasciitis. And that also gives us lots of different clinical outcomes because we didn't get the right input in working out what the condition was. So because of that, I've become the head of a national campaign in the UK, which is called Pods Heals Heal. So we're basically trying to raise the awareness of heel pains to the general public, because there's so much disinformation and misinformation out there within the public sphere about what is plantar fasciitis, how do you do with it, the plantar fascia being described as a muscle, ligament and tendon when it's none of those things. So we're really trying to raise awareness of the fact that this plantar fasciitis is not the catch-all term for it. So we did a survey of the 448 podiatrists within that campaign group of things that they commonly have referred into their clinics that are called plantar fasciitis. And we found 42 differential diagnoses that are commonly called plantar fasciitis that when they're actually examined by the podiatrist isn't plantar fasciitis at all. And as you can see in the top left-hand corner there of the images, you've got all these different varieties of places that people would commonly call it plantar fasciitis, but that actually aren't. So what tends to have happened in the last 5 to 10 years is people prefer to use this term plantar fasciopathy rather than plantar fasciitis, because that can be used as a catch-all term for plantar heel pain rather than using plantar fasciitis. So clinically that is more accurate. Plantar fasciitis is a specific condition or a couple of conditions, as we'll go through in a minute. But again, it's probably a little bit clinically lazy to just call everything plantar fasciopathy instead of plantar fasciitis. What we really need to do is work out what the tissue is we're dealing with, what the mechanism that tissue is becoming injured is relating to, and then we can start to work out a treatment plan for that individual rather than, again, just swap one catch-all term for another. So plantar fasciitis is pain in the region of the medial calcaneal tubercle at the origin of the mid-band of the plantar fascia. So unfortunately, my cursor is not working on here to show you, but if you look at the bottom images there, you'll see that on the MRI scans, the left two images are classified as plantar fasciitis, and the right two images are classified as plantar fasciitis. So we have plantar fasciitis being subdivided using ultrasound or MRI into a thickening of the plantar fascia at the medial calcaneal tubercle and a thinning of the plantar fascia. So I get reports coming in weekly, daily for patients who have been diagnosed with plantar fasciitis, and it genuinely is plantar fasciitis as found on MRI or ultrasound. But some of them have got a thin plantar fascia and some have got a thick. So again, we've got to think what's caused that change in the plantar fascia tissue, and do we give those two groups of people the same treatment plan? We can further subdivide those two groups of plantar fasciitis into an inflammatory stage, so under 6 weeks, and a non-inflammatory stage or chronic stage that's over 6 weeks. Now, obviously, that's a relatively arbitrary cutoff, but it's clinically useful in the cold face when you're not necessarily going to send people for MRI scans and stuff to try and change your treatment planning. So, you know, one of the common criticisms of the term plantar fasciitis is the itis part of that infers inflammatory, and a lot of people who will end up in your clinic don't actually have an inflammatory condition. It's past the inflammatory stage and is therefore not going to respond to those sorts of anti-inflammatory treatments. So we've got to differentiate our plantar fasciitis symptoms as to whether they are relatively new or whether they've had them for a while, because that's probably going to change our approach, certainly on the rehab side of treating plantar fasciitis. But today we're going to primarily focus on the orthotic elements of how you might approach plantar fasciitis or heel pain problems. So first case study, plantar fasciitis. I'm going to go through demographics, and then we're going to talk about the different levels. So I hopefully repeated the same format. So we've got a 45-year-old male who has a repeated history of short-term right-sided heel pains. So my definition of short-term is under 2 months. So they've had repeated right heel pains that only last for a couple of months and then they sort of go away, which is, again, a common phraseology you might hear from your patients, and certainly some of the more general practitioners will, that's what they commonly understand to be plantar fasciitis. So something that hangs around for a bit, hurts like a lot, and then goes away. Okay, because he's had this condition for some time, he's got foot strengthening exercises and he does some stretches after his running. Okay, he's got no other health conditions. He's a recreational runner, but having said that, he's a pretty good one. So he's sort of coming in the top 10 for park runs. That's something we have in the UK, a regular timed event 5K every Saturday morning. So he's participating in that, but he's coming in the top 10 for his age group. And he's got over 20 years experience of running. So this is not someone who's new, doesn't know how to train for their issue. They just keep getting heel pains every so often. Okay, today presenting with the right side medial heel pain. So his conditions come back and he's going to try and sort it out. This time it came on after running in a soft footwear on sodden ground. So he was running in sort of what would be road trainers, and the ground was, he took it off road and it was just much softer than he was expecting. And his heel pain re-emerged after that. He's only had it for 3 weeks, but he knows what it is. He just wants it to not keep coming back. So he's not tried any new treatments or additions to what he normally does. He's just seeking some additional help. He gets pain on rising after long and after long standing. So when he's standing, walking, it's hurting when he does it for a lot of time. So all the classic symptoms that you would be looking for a plantar fasciitis. But it also gets worse when he puts those soft running shoes back on again. So when he's put in a softer environment, then the heel pain is more acute. So on examination, we find, as the image shows there, pain in this region. All right, so if you have pain that is not in that region, it is not plantar fasciitis. It's one of the other plantar heel pains, and it may involve the plantar fascia, but it's not this sort of thinning or thickening of the plantar fascia. All right, so it's got to be in that area to be a plantar fasciitis. If it starts migrating further into the arch of the foot or laterally or medially, again, the plantar fascia may be implicated, but it's not your classic plantar fasciitis that we're talking about here. He's got no neurological signs. He's got tight calves, which again quite common for runners, but both groups of his calf muscles are tight. All other muscle powers are good, which we would expect. He's doing his foot strengthening exercises, but he does have quite a high tibial varum angle. So this sort of pitched angle that holds the foot more relatively inverted in relation to the ground. So essentially his foot's dangling off the end of an inverted structure relative to the ground surface. The left side shows an increased or an above average range of pronation. So what we mean by that is we can take the foot through, and he can put his foot through, his ankle through a greater degree of pronation than we would consider to be average. So I'm deliberately not using the word overpronation or anything like that. It's just an above average range. I mean, he has more pronation available to him. There's no other foot morphologies. So if we look at frontal or sagittal plane postures of the foot, they are relatively neutral relative to each other. In gait analysis, sorry for that, we've got my little baby just made an appearance there. In gait analysis, he displays a relatively increased rear foot eversion and a low navicular height. So when we watch him walk and stand, the increased range of pronation that he has available to him is causing his calcaneus to roll further outwards relative to his tibia, and the navicular to be lower. So we're seeing a result of that pronatory movement, and it's again more on the injured side than the uninjured side. So our clinical assumption here is that he's overloaded the plantar fascia at its origin, but it's still within the acute phase. So you'll notice I put on the top right hand corner a couple of little bits just to remember who we're talking about as well. So he's still in the acute phase. It's only 3 weeks old since he's re-injured it, re-flared it up. So we feel clinically that it's related to the increased range of pronation. So the right is using that range of pronation to accommodate for the tibial angle more than the left is. So essentially every time he takes a running or walking step, he has to go through a bigger range of pronation to get that foot plantigrade, because the tibia has a varus angle on it, and the right has more capacity to do, or requires more capacity to do that. Okay, it's exacerbated possibly or probably by tight calf groups. That reduces the sagittal plane function. If you're unable to get your tibia past the vertical position, but you have pronation available to you, you'll often try, or the patient will often try and use pronation to allow that sagittal plane function at the ankle without having to lift the mass up higher. So essentially that might account for seeing the lower navicular as well at that point, but it's all increasing the internal forces on that plantar fascia. So they're having to resist the pronatory forces and the elongation forces as the foot goes through its stance. We are also assuming that the unstable running surface increased the effect of this. So basically, if you stick a foot that needs to pronate more and use a secondary pronation to account for the tight calf groups on an unstable surface, it's going to make those plantar tissues work harder. Okay, so we feel that that's exceeded the zone of optimal stress. Again, if that's not something you're familiar with, I'm not going to go through it today, but essentially it's pushed the tissue past its ability to cope with the stresses that it's on, and he keeps doing that. All right, every so often something will trigger it to be more of the stress than it can cope with. So our aim is to reduce the internal and external stresses on the plantar fascia, returning the patient to running as soon as possible and as pain-free as possible, and we want to keep them running. So really, he's tried the things that should have worked. So foot strengthening, calf stretches, knowing how to train, those things should have got rid of his plantar fasciitis, but because it keeps coming back, he's now on the radar for orthoses foot orthoses as an intervention. So as some things to consider for the orthotic itself. So one of the things we're going to do is essentially belt and braces, bring the ground up to the foot. So with the Arkad solution, what we would do here is essentially, because it's printed on a flat base, we would pitch the entire shell medially by the amount of degrees we felt would mean that he didn't have to use that pronatory range of movement to accommodate for the tibial varum angle. And the way we do that is in this screen, when we've imported in the scan, we then pitch the cast relative to the planal surface, so relative to the print surface in this case. So what we would then do is use the y-axis to essentially nudge the big toe up, the big toe side up, not the big toe specifically, but because it's a standard cast, if we wedge it as an entire over and it's printing relative to a flat plane, that will bring the ground up, or the orthotic reaction force surface up medially relative to the tibia. So that should mean that the patient doesn't require to go through that, use that increased range of pronation he has available to him. So again, having a big range of motion for pronation is neither a good or a bad thing, but this person is having to use it to the extent that it's exceeding the plantar's tissue's ability to resist it. Okay. We might consider a deep heel cup to stabilize the calcaneal function in softer terrains or footwear. All right. So if these are footwear that the patient finds particularly comfortable and wants to continue using, we might account for that by putting a deeper heel cup in. Again, you've got to have space to do that within the shoe as well. We might consider bringing the peak of the arch height more proximally. So if we peak that underneath the substerntaculum tali rather than under the navicular, which is dropping, that should be a more comfortable, for want of a better word, support for that pronatory range of motion. But this patient currently has a hurty bit. So the plantar fascia is hurting when you press on it. It's hurting when he works it. So one of the downsides to an orthotic up until this sort of technology is you had to just deal with that. You either had to put extra padding on it or just break in really gradually, or wait to use the orthotic until the patient was well enough to tolerate it, because we're going to be putting a orthotic reaction force pushing up just at the bit where the plantar fascia is currently inflamed and painful. So because we've got all of these nuances of material selection, what we can do is just put a little patch pardon me, of softer material under that area that's painful for the patient. So as they accelerate onto the insole and the insole resists that with its deformation characteristics, we can allow it to deform slightly differently under the hurty bit. So that should make the insole more tolerable and meet our treatment aims of getting this patient running back as quickly as possible and pain-free as possible. Okay, we would use a generally firm insole to make the device useful in lots of different footwear types, particularly considering this person may be using it quite regularly. So we want the durability of that device to be quite high as well. So in the treatment planning side of things, we want them to do gastroc and soleus, so triceps zero stretches. And I would advise that they do these stretches at least for the first 6 to 9 months, considering his age, onto the orthotic insole, so that rather than using pronation to allow the sagittal plane tension of the gastroc soleus complex, pardon me, hopefully if we train that tissue within the shape of the insole, then he gets that benefit longer term. After initial breaking in, again, every insole has its own breaking in period, and your clinic will probably have its own protocols around that. I would suggest that they use it for all activities of daily living as well as running, while we're getting the tissue adaptive response to the orthotic insole and the symptoms reducing. So once the symptoms have abated for more than a 2-week period, so we don't want to take the insole away from day-to-day activity too soon, because we want that tissue to readapt and become nice and calm. So once they've had a good 2 weeks of no heel pain symptoms, then maybe we just use it for running activities. Okay, I would look to review the insole outcome. So have they tolerated the insole? Has it achieved our aims? Can it fit in the shoes? Those sorts of things a couple of months after use. And because this person has got repeated bouts of this plantar fasciitis, what we want to do is make sure that it's not just calmed down on its own. The orthotics had the effect that we're after of keeping it away. So I would probably recommend a 12-month review for this patient as well, which hopefully is a nice simple review where he tells you how wonderful you've been and your orthotics wonderful and changed his running life. I would then look at continuing to use the orthotic insole for running activities, probably in perpetuity, because we're not going to change that tibia. He's already done strengthening exercises to try and account for it. It's not been sufficient. He's getting older, wants to be out there running. So I would say insoles for running activities from now on. Okay, so hopefully that is covering that one. So we'll have a look at a slightly more left field heel pain, excuse me. So we've got pain at the apex of the calcaneus. So again, this is something that I see quite commonly, but I don't think it's that common in the population. And I think that that tells me that this is a type of heel pain which doesn't go away with the stuff that you would normally do for plantar fasciitis, but it commonly gets called plantar fasciitis. So we're, just as my finger is pointing at on the image, we're talking at pain just at the apex of that calcaneus. So in this case, it's a 68-year-old female. She's got well-controlled high blood pressure, but otherwise no other medical conditions, so nothing that we really are thinking is going to impact our treatment planning from there. She's reporting pain at the back of her left heel bone more than her right, but they're both painful in the area that's indicated there. The pain increases as the days goes on, with increased activities, and some pain initially on rising. So again, this person will probably have been given the diagnosis by ChatGPT of plantar fasciitis because they meet that sort of what we're listening for criteria of pain first thing in the morning that gets worse later on in the day. Okay, they had a gradual onset over the past few months. So this didn't come on in one go. They didn't have a single mechanism of injury. They built it over time. So she's recently semi-retired from office-based work and has been increasing her walking since retirement with the aim of being much healthier than when she was working. So she's really quite frustrated that she's been doing all this good work and the heel pain's kicked in and is now stopping her. So she essentially walks until it wears off. So it will wear off if she just keeps persevering. But she stops if it gets too much, but this is her own self-reported wearing off and too much. But essentially, she's pretty determined that she's going to keep going, walking through this. She's tried heat and ice, but to no effect. She's heard lots of different things about heat and ice, but it hasn't worked for this particular thing. So what we see on examination is the pain is not repeatable. Okay, so I can't make it hurt. If I press on it, tug it, move it around, it doesn't hurt. All right, it's only when she weight bears on it and moves on it. Functional and muscular tests are all negative, so everything's sort of powerful and works in the way we want it to, but she does have osteoarthritic changes in first metatarsal pharyngeal joint in the left side more than the right. All right, so she's got a bit of arthritis, reducing the amount of dorsiflexion available at the hallux. She also has some osteoarthritis in the left talofibular joint, which again we don't have a direct mechanism for, but she's, you know, so she's lived a life. It's possible she sprained her ankles, things like that, but we've not got a direct mechanism for it. But she's got a bit of osteoarthritis in the talofibular joint, so she's unable to bend that quite as well, and the fibula won't move out of the way quite as well. She's got an average range of pronation, so she's not especially able to pronate or supinate her feet above average. She's got no other foot morphology issues. She gets pain initially on standing and walking. In gait, she displays a reduced ankle and first metatarsal pharyngeal joint range of movement. So she's basically got sagittal plane block reduction at both the ankle and the subtalar joint, and we know that part of that's coming from osteoarthritic changes. She compensates for that with an early heel lift, so left is lifting earlier than right. And when we looked at her work shoes, they have a relatively large heel drop. All right, probably a little bit less than the picture I've got there, but a bit of a heel drop on there. And then her walking shoes that she's been working in are relatively flat. So what we're looking at here, our clinical assumption is that the mechanical pull at the intersection of the plantar fascia and the Achilles tendon is the point of pain. So on this image, it's the best one I could find to demonstrate this. We've got a tensile load going through the calcaneus from the tug of the plantar fascia, and we have a tensile load going through the calcaneus at the tug of the Achilles. In our anatomy exams, we tended to end the Achilles around the plateau at the calcaneus and start the plantar fascia at the medial tibial cubicle. However, in terms of tensile load, the calcaneus, as it moves into the second sort of half of gait, is really starting to act like a sesamoid bone. It's translating the pull of the calf muscles into the plantar fascia and the plantar fascia back to the Achilles, and it's doing it around the fulcrum of the first metatarsal pharyngeal joint. So in this case, the pain is where there's nothing. So if you look in your anatomy books, there isn't really anything there to be hurting, but the patient is getting pain and we can't make it hurt. It's only occurring when she's loading it, working it, moving it. All right, so we're working on the assumption that it's those two pulls that are pulling against each other. So this is related to the sagittal plane restriction in the first metatarsal pharyngeal joint, creating a longer lever arm for ground reaction force to put a tension through the plantar fascia. So essentially, rather than, if this is the first metatarsal pharyngeal joint, as you lift up, it's bending, as you lift up, it's straight. So the plantar tissue has got an increased lever of arm of 4 or 5 mils, which on its own may not be a big thing, but it's an additional stress that tissue is having to cope with. The lateral osteoarthritic changes create an increased pronatory force as the foot enters mid-stance. So essentially, because the fibula is stiff, as you start to go into sagittal plane, as you start to go past mid-stance in sagittal plane, the foot's got to try and achieve that because it's being driven by the other limb swinging past it. So in order to achieve it, she's only got an average range of pronation, and she's already got a sagittal plane block in the first metatarsal pharyngeal joint, the force coupling that's created at the dorsal surface of the talus is going to create a pronatory force. So whether you see that or not, there is an internal force being created that's stiffening all of that tissue in the plantar and posterior elements of the foot and ankle. So she's compensating that by lifting it early. So because she can't achieve the sagittal function she's trying to, she lifts the heel early, which is probably what's causing the pain in this area rather than a different part of the foot. So she's essentially taking that load for longer. It was probably previously masked by wearing footwear which has got a small heel, and activity that wasn't as robust as what she's doing now. So because she's upped her activity, she's increased the load for this internal and external forces going through those tissues, and she's flattened the heel slightly, so she's got rid of some of the cheat that her body had become accustomed to. That may or may not be contributing to her generally reduced ankle range of movement, which is more soft tissue. So our aim is to reduce the internal forces and deal with the apex of the calcaneus area. So we want to allow her to walk more functionally, and there are definitely some things that we cannot change here. So she's got some arthritic changes which we don't have the power to reverse, so we've got to accommodate for them. So again, she's a good candidate for orthoses. So the sort of thing that we're going to do here, we might do some medial rear foot posting on the left to reduce the stiffness, with a reduced stiffness to decelerate the pronatory force. All right, so where again you might not see the pronation occurring from this stiff lateral ankle, we know that it must be occurring to achieve sagittal plane function. So the thing we can do there is, previously with an orthotic, what we would have to do is build a stiff shape under it. And what we really want is a shape that's going to bow within, take a bit longer to flex, so that when she walks, she's got deceleration of that internal pronatory force as she moves her contralateral limb past. So what we want to do is build and we don't need to do anything fancy with the shape of the arch, we just want that to decelerate that range of pronation. Okay, forefoot posting to allow increased drop of the medial column relative to the lateral. So reverse Morton's essentially. So this is what it looks like on the device. We've added a reverse Morton's, which is essentially a rectangle that we've smoothed. Because we've got the cast imported, and we can also import foot scan data, we can see exactly where that first metatarsal pharyngeal joint is sitting. So by raising the lateral columns relative to that, we let it drop down a fraction, which tricks the foot into thinking that it's got more sagittal plane function at the first metatarsal pharyngeal joint, and hopefully take some tension out of that plantar fascia element of the issue, as well as she doesn't hopefully need to lift her heel up as early. So we again would give her some calf stretches, possibly calf mobility exercises. Again, I would suggest doing that while wearing the orthotic. So we're training the tissue into that range of movement that the orthotic allows. I would suggest 6 to 12 months use of 2 to 6 months of some form of adjustable heel lift. So this is an addition. This is not the orthotic prescription. This is something we're sticking under it with layers on it, and then as she increases the mobility, her flexibility, and her tolerance to the load, so as she increases her activity, hopefully we can lower those heel lifts down to the point where she doesn't need those at all, and it saves us putting that in the prescription, because hopefully she's not going to need that in the long run. Again, I'd review in 2 months for the orthotic and 12 months to see if we've achieved with that adjustable heel lift what we were hoping. So if she's done her exercises and she no longer needs the heel lift, that's us done. The orthotic's good to go, just accounting for that sagittal plane function limitation of the first metatarsal pharyngeal joint. If the load tolerance cannot be achieved with that method, if she can't walk as far as she wants to or be as active as she wants to, then I might consider footwear with a bigger heel drop. So she might choose to do that anyway, because she wants to be out there quicker. But my suggestion would be if we can accommodate it, use the heel lift in the medium term, and then we can hopefully build her resilience to that activity. So it doesn't really matter what footwear from this perspective that she's using. She just needs something that's fit for purpose. Whereas if she can't build the tolerance to it and the orthotic is not sufficient to allow that, then we might have to start doing some footwear choice discussion as well. Everyone's favorite thing. So I realize this is recorded, so if you have got any questions about it, obviously email Ruben. Please email me, so it's ian@bx-co.com. So please feel free to email me on that one. And again, follow those. I do run my training course. I bit plug for myself there. So the training course, if you scan that QR code, it will give you the information about, there's an online 5 hours of CPD that goes through anatomy, functional anatomy, biomechanics, and then some orthotic considerations that you can use for prescribing your devices. And then that might lead you to prescribing through us, hopefully. So again, just to say thank you, and I'll hand over to Ruben.
Ian, thank you so much. That was a really amazing presentations. I did lots of information. I don't know how people are gonna digest information. There's lots. Thank you so much, Ian.